Very good morning, everyone. I will be presenting my paper on management of large angle exodeviation with a hangback.
I would request all the presenters to stick to time.
So I'd like to acknowledge this previous study of ours, from which I have followed the surgical dosing and methodology. Management of large angle exodeviation is a challenge since less than 50 prism diopters, any surgical dosing can give optimal results. But whenever you do surgery for more than 60 prism diopters, the results are suboptimal, especially if you perform surgery in single eye with the normal surgical tables. And if you do excess of resections, then you can result with lateral incompetence or diplopia and narrowing of palpebral apertures. So this is a retrospective study done from October 21 to 23. All the exotropias measuring more than 60 prism diopters were included with a minimum 6 months of follow-up, and all were competent squints. And patients who had a tight FDT before and during intraop, recession was further done, and limitation of abduction was scored as 0 to 4, and narrowing of palpebral aperture more than 2 mm was considered significant. This is the surgical dosing which I followed, and lateral ictus is fixed at 9 mm, and further recession effect was given with by hangback technique with the help of 60 polygalactin suture. A final deviation of within 10 prisms under our overcorrection was considered as surgical success. And these are the results. I have 20 patients between 60 to 70, and 12 patients between 70 to 80, 7 patients 80 to 90, and only 3 patients more than 90 prisms. And the mean pre-op deviation was 72 prisms. Majority of them had a primary exodeviation. So these are the few examples of our cases: 60 to 70 prism diopters who had a good cosmetic correction, and these are the patient who had more than 70 prism diopters of exodeviation which got corrected. And these are special mentions. The first patient had a simultaneous pterygium surgery, and the bottom 2 patients had were maternal twins, of which only one had a good correction. The other had more than 80 prism diopters, so she had suboptimal correction. And the top right patient had good correction. Despite that, he was having diplopia complaint, for which I had to give 8 prism. And only 7 patients in my study had abduction limitation. As you can see in the top pictures, these are immediate first day post-op and 1 week post-op. There will be mild limitation, but by the end of 3 months, the limitation resolves completely. And there will be mild palpebral aperture changes where patients don't notice it. Only one patient had reported significant narrowing of palpebral aperture because of the ptosis. This patient had multiple previous surgeries. My surgery was the 3rd surgery, because of which there was weakening of aponeurosis. And this is the summary of the results. As you can see, all the angles of deviation had good correction. And so to summarize, the success is if the prisms is less than 80 prisms, then the 90% success can be obtained with the hangback technique. And if it is more than 80 prism diopters, even you can get up to 80% success. So on literature review, the first person to address the large angle deviation management was Reiner and Jampolsky, who had performed in amblyopia, and they had 15 years follow-up. They have done up to 9 mm resection. And they even said that leaving lateral incompetence is better for the patient. Paul Owens had done intraop Botox along with 10 mm resection and recession. They had 66%. And even Chang and reviewing literature, it suggested that anywhere between 80 to 100% success rates are there if you do resection of MR from 8 to 12.5 or 11 mm. So discuss lateral rectus recession up to 9 mm can maintain the rotational ability of eye, and further hangback technique with 4 to 6 mm can maintain the rotational ability. It will only weaken the abduction movement. And if the belly of MR is thin, then you can do resection even up to 7 mm. If it is thick, then you can do up to 6 mm without including the bulk. As now there is a rising trend of muzzle transplant technique, the hangback recession has equal advantages, and in some cases superior advantage in terms of lesser learning curve, lesser surgical time, easy reproducibility, and equivocal results. So to conclude, large angle exodeviation can be managed in single eye. As in majority of the large angle exodeviation, patient psychologically feel that the squint is only in the one eye. They don't want you to touch the other eye. And as the surgical time and surgery is eased, you can perform it. And even single eye surgery can reduce the financial burden in patients. Thank you.
Thank you, Dr. Sujit. I think yes, for large angle exodeviations, that's always a tricky situation. So hang back recessions that you have done, what's the maximum follow-up you have seen?
Even I think more than 1 year follow-up I had
More
seen.
than 1 year. So have you seen any reduction in your effect, a regression later on? Because
Nobody, I mean, follow-up, maybe less than 10 patients are there for
Okay.
more than 1 year, but none
Okay.
of them had complained as such.
because we expect that since there's not a spacer there, so
Yeah,
it
yeah.
has a tendency to creep forward.
Yeah, yes, ma'am.
That
I
is
had
what
an
I
OCT
wanted to
image
know.
in that picture, that laptop I have uploaded.
Okay.
So OCT, basically the hangback what we leave with polygalactin suture, the T-lens grows over that suture.
Okay.
And even as you said, creeping of lateral rectus muscle has been described
Yeah.
in cadavers up to 2 mm, 3 mm. Like
And none
that.
of the patients had complained of diplopia because
No, no.
it's like an incompetence that
Yeah,
we
ma'am.
are.
I usually check prior to doing surgery with the prism. I
Okay.
ask them up to what limit they are having this diplopia complaint
Okay.
and plan accordingly. Majority of them never complained of any diplopia. Even if they complain, that diplopia will go away by 1 week or 10 days. So nobody, only one patient had complained, but that was more or less looking
Temporary.
ortho.
Okay.
Because of slight overcorrection, that patient was also having mild mental retardation and abnormal head posture. So I had to give 8 prism diopters base out.
Okay. Thank you, Dr.